So still, I think 2 minutes to go.
Yeah, just 1 minute.
Okay.
Should I share my screen already or not yet?
Not yet.
Okay.
So Dr. Pratik will introduce first and then we can start. Okay, we are live. We can go ahead.
Sir, unmute करो sir. Pratik sir, unmute करो.
So good evening, friends. I hope we all are here together this fine evening, and I thank you all for listening to us, to connect with us, and from the Ortho TV and from the Zoom I thank you everyone for this interesting case series. Today we are here to discuss about the elbow instability. It's quite a neglected topic. We have with us a tremendously great speaker from Germany, Dr. Christos, and he has done his work in arthroscopy and sports medicine. He will talk about elbow stability and internal bracing. And we have with us Dr. Arvindo, from Arvindo, Dr. Asim Negi. He has been very famous in carrying out his work on elbow trauma and instability. So apart from this, I will welcome Dr. Karthik and Dr. Tejas to connect with us and give us this opportunity to connect to you. Oh, so I would request Dr. Christos to please take over and share his talk with us.
I have to thank you all first. From no, it's not. Sorry. Yeah, I have to thank you all and for the invitation for having me here to talk about the elbow instability and the internal brace. I would like first to actually refresh our anatomy by just saying that the lateral and the medial collateral ligaments are not just one ligament, they are like a complex of ligaments. And especially we know the last years that especially on the lateral side, the LUCL as the ligament that plays a really important role. We have the static and the dynamic stabilizers, static extensors. I have some noise in the background. Yeah.
Go ahead, sir.
Yeah. And of course, the dynamic stabilizers, as we know, are the muscles that cross the elbow, and of course, anconeus brachialis in the triceps. Sorry, but okay.
Just click on the slide. Yeah.
It's moved now. Yeah.
The elbow dislocations. Actually what we get as an elbow dislocation mostly is a posterior one. It's more than 90% of the cases, and mostly is the posterior lateral we see on this X-ray. All the other ones, the anterior lateral and divergent, are really rare, at least in Europe, I have to say, because maybe in India it's a bit more common than in Europe. The mechanism is mostly is actually it's when we fall in an extended arm, as you see here in the left bottom picture, with axial compression at the same time supination and valgus stress. What gives us at the end of the day this circle of Horry. That's what O'Driscoll actually described. And what's really important here is that It doesn't start from the medial side, it starts from the lateral side with a rupture of LUCL, and then it goes further to the capsule ventrally or posteriorly, and then eventually the MCL. And here on the bottom right, we see the stages that we have. The instabilities that we have is what we just described, is the head fractures produce an valgus posterolateral instability, because isolated radial head fractures are really rare. If we see in the literature, we see even the Mason 1 radial head fractures have a combined ligament injury, even the Mason 1. And that's why we have to do further diagnostics there as well. On the other side, we have the varus posterior medial instability. That's where we get an LCL tear, and at the same time, we get a fracture of the anterior medial fragment of the coronoid. And in this case, we don't have a radial head fracture, and we see how the mechanism, what the mechanism looks like on the picture here. If we want to classify the instabilities or the dislocations in a more simple manner, it would be, and the complex ones are Monteggia-like head fracture, as we said before. I don't want to go into detail and explain the Bado classification, Jupiter classification, because you can find this in any textbook. What's really important is time. If you have an acute dislocation, it's considered acute the first 2 to 3 weeks. So the window that we have is really narrow. It's a chronic one after 6 weeks. That means that we have a gray area, a gray zone from 3 to 6 weeks. And that's important because we have to know the quality of our ligament. And that's why where the internal brace comes into place. I'm going to show you a couple of cases afterwards. The chronic instabilities mostly are caused by recurrent dislocations, a failed conservatively treated dislocation. According to Arrigoni, they're related to dorsal-radial plica, and the ones that we haven't seen, and they persist with a chronic instability, they come to us by having tennis elbow-like symptoms. That's why it's really important to do a differential diagnosis and to differentiate between tennis elbow and PLRI, posterolateral instability. Of course, we can see chronic instabilities after microtraumas or cortisone injections. What we actually every now and then see is like a misdiagnosis in the A&E. The resident doesn't see any fracture, doesn't see any dislocation, because the head get to the posterior side and then comes back. It's like a subluxation, so we don't see it. And of course, on the other side, we have the overuse chronic instabilities that, for example, the valgus overload syndrome, where we see it with posterior medial impingement by throwers and pitchers. You have to have actually much more cases with cricket in India than in Europe, because we don't really play baseball or cricket. Diagnostics. What we do, of course, a clinical examination, but if you're not the one that has done the reduction on its own, then in acute phase, it's really hard to actually examine the patient. Maybe in a week or 10 days, as we said, the window is really narrow. Otherwise, in chronic situations, you have the pivot shift and the drawer test, what we get actually from the knee surgery. What we use in Germany is a forceps grip test. What is this? It's really similar to the drawer test. We take the radial head into our 2 fingers and we just press the posteriorly or posterolaterally. Of course, what we have the push-up, the stand-up test, and for the medial side, the milking maneuver, valgus stress. And if you can use an ultrasound, of course, you can do a dynamic examination. And you can see how the joint opens up. All these examinations, there is on the side for AGA and DVC, that's the society, the arthroscopic German society, and for shoulder and elbow surgery, PDF file with all the clinical examinations you can find there. It's in German, but there are enough pictures where you can see how it's done. Further diagnostics, of course, an X-ray, a CT scan is a must. We have to do it, and an Osborne-Cotterill lesion, a lesion that's kind of forgotten, and we for example, in the first region of the LG instability. And if we see in the literature, a German elbow surgeon, Mader, has done a sequence of it, and he showed the superiority of the operative treatment in comparison to conservative treatment. What I do in my practice before I go on and operate on something is an MRI to evaluate the soft tissues, especially the tendons. Why? That's first for me to decide if I'm going to go and treat it conservatively or operatively. And at the same time, for me, it's really important. So it's a sign to use an internal brace on top of it to augment my repair or not. And that's what we see on the bottom right, where we see a complete flexion rupture. It was a part of. And the CT scan, sometimes in good X-rays, what we see is the drop sign. Drop sign is when drops, and it's not in the same level with the capitellum. And of course, as we said, the Osborne-Cotterill lesion. In chronic or in acute to chronic cases after 7 or 10 days, where you see the patient and he still has, for example, a deficit, or she still has pain, and you can get an appointment, for example, for an MRI, because we know how hard it is. In my hands, the best diagnostic tool is the elbow arthroscopy, especially in chronic conditions. Why? Because you can get right away an answer if it's stable or unstable by just using your trocar. In the first picture, you test for the annular ligament. If you go further to the ulnar side, you test with your trocar, and you see here, that's the humeral-ulnar joint. It doesn't open up. That means we don't have any posterolateral instability. In comparison to the picture, to the image on the top right, where you see how the joint opens up when we put our trocar in there. That's a case, that's a pediatric fracture that wasn't operated. This lady, now 54 years old, I'm going to show you what we've done with her in a bit. And that's how it looks like. That's an Osborne-Cotterill lesion, this young lady here, and in the drawer, how the react comes up here in this video, and how it's done arthroscopically, which you have seen on the pictures. Here, though, is not the same patient. There was a patient with OCD lesion and a loose. So our therapy, as always, either conservative or
Dr. Christos. Yeah. Your internet has been very unstable, Dr. Christos. You're muted. We can't hear you as of yet.
Dr. Christos.
Now?
Yeah.
Can you
Now
hear
we
me
can
now?
hear you. Now we can hear
We can
you.
hear, but picture is not there.
So I think your internet speed is a bit slow.
Yeah.
You can stop your video and continue with the slides, so that will keep the bandwidth good.
Okay. Yeah, it must be slow. As I said, conservative treatment is not an option for young people in my hands, because especially in Germany, it's a German school. There are like lots of papers from Schnetzka who shows as well the superiority of the operative treatment in comparison to the conservative treatment. Of course, in case we go for conservative treatment, degrees of flexion, and in any case, we have to do a follow-up of the patient after 7 to 10 days, because we might see the instability might change. On the other hand, the operative treatment, we have to do either repair LCL or MCL or both, and repair plus this internal brace. When do we mostly do that? In this gray zone, as we said, 3 till 6 weeks, and I've become actually a bit more aggressive with it, and I use it quite a lot on the lateral side, standard actually, because the posterolateral instability is the one that causes the most problems. And of course, as I said, I see my MRI, and then I decide if I have a tendon rupture, then I do it. I do it there as well. A hinge external fixator, although it's really in Germany, it's not an option in our clinic because we have the internal brace. Where we don't need a hinge external fixator because it's so stable. I have some case examples here. That was a 55-year-old lady fell a week before she came to us, and she was sent to us by her doctor. She had no neurological deficits. Her X-ray was okay, and the CT scan, no fracture. And of course, in the clinical examination, we saw lateral and medial instability. And as I said, so I do an MRI before I proceed with the operation. And here we can see, as we saw before, the flexor rupture, and at the same time on the lateral side, it was a partial extensor rupture. The operation, I don't want to exaggerate here, but this is unstable from medially and laterally. And that's how internal bracing is done. Actually, we use a 3.5 Nautilus anchored together with fiber tape. And then we use a poker approach. And then we go to the supinator crest. And then we dunk our anchor in there. The supinator crest is exactly posteriorly from the radial neck. And we do it like in this direction, because we know that the bone there doesn't have a length. At the same time, what you see on this picture is the whole the ligament, the LCL complex, which is armed with fiber wire. What's really important is to find the isometric so you don't get any deficits or pain after using your internal brace. And point most of the time is either the middle of the capitellum, as you see here. You find there, you go back, and what you do there, you bring your anchor, your 4.75 anchor together with your armed ligaments with the fiber wire in there, and you have your construct. Actually, the internal brace together with your repair. Oops. That's the medial side, and you see the flexure rupture that we saw already on the MRI. And I had just to free the AMCL there. And what I did is exactly the same with the ligament on the lateral side. You have to arm it with a fiber wire, and then you have to bring your anchor exactly, and not where the epicondyle is or the condyle, exactly in the middle where the epicondyle starts. Actually, exactly as you see it on this image, and on top of it, you bring the anchor, the nautilus anchor, together with your armed AMCL in this case. And then what I do, I don't use a single bundle internal bracing, as I use a double bundle for AMCL, a PMCL. And what I do in full flexion, I bring a 3.5 anchor medial to the sublime tubercle, and then in 60 degrees of flexion, I bring my second 3.5 anchor as an AMCL in lateral to the sublime tubercle. And that's a good thing about internal bracing. You can mobilize the patient straight away. They get a brace, and the only thing that I do is a deficit, an extension deficit, 10 degrees just for the lateral side. And this is the patient exactly after 6 weeks. And you see here, the range of motion is pretty good. Maybe she has, I'm going to show you here, yeah. She has not even 10 degrees of extension deficit, and she manages like 110 degrees of flexion. It got much better actually after 3 months. That's an interesting case. That's the lady that I showed you, 54 years old, with a pediatric humeral, supracondylar humeral fracture. And she had a chronic LCL complex insufficiency. She didn't want to have an osteotomy because she read it up on the internet. She found that there is a 16% failure rate of the osteotomy. Okay, so we want to do something in between. So I talked this thing with her to correct it with internal brace. And that's why it looked before we started with the surgery. Here we see the ligament, the insufficient ligament. And then after that, we defined our isometric point. Of course, we must bring our elbow to the valgus side, and the same to correct the varus deformity. And that was our construct. And at the end, with the internal brace. On top of that, because I want to have some extra safety, especially in this procedure, I did a double row technique, and then I repaired the extensors with I brought a push lock anchor here. So it's like a double row technique, what we know actually from the shoulder surgery. This is the patient after the procedure, and you see here that the deformity is corrected. It's not fully corrected, but here till she gets the osteotomy, it's much better. I've seen, sorry, 5 months now, pain-free. We're actually waiting for the outcome 1 year, and we're going to publish this case, neglected, and we treat it conservatively. And that's the lady that we saw in the beginning. And then here, I what I do, I don't use just one anchor in the isometric point. I use two anchors, one for the RCL, one for the origin or stable. Of course, you can use this one anchor, but this can you still hear me?
Yes, yes, we can hear you, but not seeing your presentation.
No.
So
Now you can see it.
you can share again.
Okay. So as I said, I don't know if you heard that. So I use always two anchors for the origin of the RCL and the LUCL. I find as a pattern much more stable. This is again just to emphasize the posterolateral instability with radial head fractures, and it's almost always associated with ligament injuries. As I said, even in Mason 1 radial cases, we brought two screws, and then we first the head, and then we brought the plate into the shaft, as you see here. But see anchors in the origin of RCL, and we're going to stay. We're going to have a pain. And of course, what we can show here, the third screw here is not there.
I think the internet is.
Yeah, did we lose him?
Yeah, I think so.
Should we inform him or something like that?
He'll be back.
Yeah.
Using the same connection. You can message him.
Yeah, that's what. Yeah, he's back, I guess.
He's back. Here's the half an hour before we tested everything. There was no issues at all. It just started once he started presenting.
Yeah, I mean, it keeps happening.
Can you see it now? Again?
Yeah, we can see it, Dr. Christos.
Okay. And unfortunately, I don't have pictures from the procedure, but I have the CT scan, the post-operative one. And you see the coronoid fragment there. We left it like this, and we just did a capsulodesis. And we had an internal brace on the lateral and the medial side, as you saw. And the patient, that's the advantage of it, that the patient can actually move his elbow in a plaster, and then you can give him a brace. And what I do is I just limit the extension to 10 degrees. And at the end, I would like to show you some results if we miss a PLRI. That was a young man. It was 35 years old. 2 years ago, had an accident. He fell on his extended arm. He had pain the whole time. In his doctors, what kind of arthritis he got after 2 years? So fast. That's why I'm always concentrate on PLRI first. And that's why I do my internal brace. That's why I've become more aggressive for the lateral side with the internal brace. And if you see here, you see a huge loose body, the olecranon fossa, and there is a mismatch. You see that his MRI between his trochlea and his olecranon, and of course the LUCL rupture. On the right bottom picture, have there a question mark, because I didn't know if the MCL was intact or not. I've done an arthroscopy on this patient. I did an arthrolysis. I've removed the loose bodies and the osteophytes. And I can tell you now the MCL was intact. And what's really, if you want, weird in this case is that the patients are pain-free directly after this operation. When I do it, I do a two-stage operation. First, I do an arthrolysis, and I remove osteophytes, and then in the second stage, I do my the patient is still satisfied. He doesn't want to have ligament reconstruction. Maybe in the future, but at this moment, he's pain-free. He doesn't have any movement problems, and that's why he doesn't need it anymore. That's as I said, the result of a missed posterolateral instability. Thank you for your attention. And I hope you can still hear me.
Yeah, we can.
And I hope that you saw and you heard everything, because I think that I have bad reception here, my connection is not that.
It's okay. Thank you, Dr. Christos. One question from my side. Can you hear me, Dr. Christos? I think he disconnected.
No, I think he's online, but something.
Yeah, but he's.
Yeah, but he's. Dr. Christos, can you hear us? Shall we go ahead with the next talk and we can have the discussion at the last? Is it fine?
Yes.
Maybe I think that is fine. Dr. Negi can share his presentation.
I think the Dr. Christos is back and he can listen.
Yeah, I'm here.
Yeah.
Negi sir, unmute yourself and then start.
Negi sir, you need to unmute yourself. Yeah.
Yeah, unmuted.
Thank you.
Should I share the screen?
Please, I think we can go ahead with that.
Yes, sir. Yes, sir. Please.
Thank you, sir. Dr. Christos, can you hear us?
Negi sir,
Yes, sir.
Can we have a informal type of discussion with your cases?
Like yeah. Bilkul. You can stop in between.
Yes.
I want it to be a dialogue.
That's great. Thank you, sir.
Fantastic.
So, yeah. Rather, I told Ashok sir, this is for opinion also. It has been seen by lots of people of various seniority and expertise, and there are different opinions. Is halfway through.
I'm sure Negi sir will challenge all of you.
Yeah.
Be ready.
No challenge. He will always stop at the top.
No. I don't know the correct answer, so it's put for opinions.
Then no one knows.
No one knows. Yeah. Even Randy Midra has seen, Parag Shah has seen, GSK, Tanna Saab, lots and lots of people have seen and opined.
So I'm sure you will be able to summarize at the end of the case.
Yes.
Yeah. Okay, sir. Go ahead.
And if Dr. Christos can have a look. It will be nice to get his opinion. Yeah.
Right.
This young lady is 26-year-old. She had a road traffic accident. It was a side swipe of thing. Some trawler, she was trying to do cycling near her home, and some trawler passed from the side, and side swipe जैसा classical होता था. One day after, initially she went to another hospital, and those guys, they did something, and I received her almost 30 hours after the injury. Next day she was in OT with me. Okay. So first surgery was done somewhere else. I couldn't get the pre-operative X-ray in the picture of the wound, but there was a large wound contaminated, which they tried to debride and put this type of uniplanar 2-pin fixator, and this was her CT scan. This whole lateral column was missing. It is not only the capitulum, the lateral condyle, capitulum, and some part of the lateral column, metaphyseal part was missing, and all this is contamination still there. These are the 3D CTs. There's a lot of comminution there. The only saving grace is that her trochlea part is not very bad, though the lateral part of the trochlear ridge is not intact, but big chunk of the trochlea is good. And head radius is fractured. There is a split. There is some small comminution and depression. So this is how she was. Plenty of small comminuted devitalized fragments. Some of them I will have to throw. But if you look at this trochlea part, this was the saving grace, that this is not very bad. Some part is missing here in the trochlea also, but big chunk of it is there. This is our classical synthes extra-articular plate, and this is put like this. So all these screws are basically going in a part which she has lost. So I'm in a soup. We twisted this plate. We did some Indian jugaad. So median side was absolutely normal, and I did not really want to open it up because there was so much of soft tissue damage posteriorly and laterally and anteriorly. So the only intact side I did not never wanted to open up. So I had to use this plate, and we twisted it almost 90 degree. So that all my screws in the distal fragment, they were going in the good bone of the medial trochlea. So this is how we fixed it. The whole lateral condyle is missing. This plate was twisted 90 degree, and then we passed all these screws in the intact medial condyle, and the proximal part was as we normally do it. All lateral structures, bone as well as the soft tissue and the ligaments, they are missing. Joint is grossly unstable. You can open it like a book, open book, but the medially we felt that MCL is intact, and probably coronoid also was not significantly damaged. There might be a small, very, very small 1 mm chip, but there was no big damage to coronoid also. The head radius was obviously fractured, and we preserved it. Day 3, she again was in OT. We debanded second time. We changed 1 or 2 screw lengths, which was short, and 1 screw was slightly 2 mm long. So we did all that jugglery. Joint was unstable, so she goes into an X-fix. All these pins were put under direct vision so that, and if you look at here, the first picture, the whole radial now, right from here, proximal to distal till it becomes a posterior introitious now could be seen there. And third day, we passed on the patient after putting the external fixator to plastic surgeon. He's a very competent guy. He used a reverse LD flap to cover it. So nice, good cover was there. And this is on day 5, 48 hours after the flap cover. Small black spot was there, but he said that it is the norm rather than exception, and don't worry, it will settle down. She goes into a vac dressing, repeated vac dressings, initially lots of oozing. In between, we grew some gram-negative organism, which she received amikacin for about 10 days. continued with wet dressing, and these are the pictures. 7 days, 11 days. We were desperate. We were telling him, "Isko skin cover kyun nahi kar raha hai?" But he was very firm. If I put a skin cover, that much of skin cover, big chunk I will lose, and no fun. So day 17 and somewhere around 26 or 27 days, we did the skin graft. 4 weeks down the line, skin grafting was done. And here she is after 5 days of skin grafting. Graft has nicely taken up now, and almost the whole wound is covered very nicely. She's not on antibiotic for now almost 2 weeks. 5 weeks she was like this, and 6 weeks. Somewhere between 5 to 6 weeks, around 6 weeks, we again take her in OT. This is the X-ray at 1 month. And around somewhere between 5 to 6 weeks, I took her in OT, kept the pins and removed the rods. This joint is congruous, and we tried to move as much as safely we could do. Joint was reasonably stable. The wound had almost healed by this time, and we put her in a hitched elbow brace and allowed her 30 to 40 degree of range of motion, whatever was possible. So this is how she is doing actively around 6 weeks. This is her active range. Then she goes into this thing, 6 weeks, 7 weeks wound, and around 2 months, the whole thing has nicely healed. She continues with active physiotherapy. Then came the lockdown. So we couldn't really put her under care of any physiotherapist. Her father-in-law is a very senior and a very respected cardiologist and a close family friend. So he was taught physiotherapy with the help of videos, and the family did the job of a physiotherapist. Then I saw her almost 3-4 months later on. This is at 5 months, and this is at 6 months. Now, if you look at these X-rays, this picture shows that the relationship of trochlea with the olecranon is perfect here. But there are views. This view is slightly hidden here. It shows that there is 5 to 6 mm of lateral subluxation. She's doing lightweight exercises. This is her flexion, can do most of the activities of daily living. About 2 pounds, I think she is doing, 1.5 to 2 pounds. And this is her video. Can you see this video? Hello?
Sir, yes, sir, yes.
Yeah. So my query is, bone is through. There is no element of infection. She can do ADLs at 6 months. I'm extremely worried about that small 5, 7, 6 mm of subluxation which I see left. So maybe month or 2 down the line, should we do something? On table, Dr. Randy Bendra felt that MCL was probably partially torn, so she's not stable. So you should do something about that. Parag said that she is already doing great, so don't touch her. You may not make her better. So what is the opinion of the house and Dr. Christos, obviously? What others feel?
I wouldn't touch the MCL. The MCL with that heals on its own most of the time, and if it was like this, I wouldn't do anything there.
Okay,
so
that's very happy.
She's happy.
She's happy. She's happy. She is not on painkillers, only calcium, vitamin D, and paracetamol SOS.
Nothing. She's happy.
Okay. Will she worsen over the next few months? In terms of subluxation? Ashok sir?
I think we again.
Ashok sir,
Yes, sir.
will you like to do something?
No, again, I agree with Dr. Christos. Since she's already doing what she's meant to do in daily life, I'll wait and watch and see if there is a problem in future, then I can address it.
Like one
Say-
more show.
Ashish sir, you are muted, I guess.
Am I muted?
No.
No. My question, is she ready to get something done, sir?
No. She is not a routine patient. She is like a family to all of us. Her father-in-law was 2 years senior to me. So she's not a run-of-the-mill patient. Whatever we will advise will be done in good faith and with in consultation. And if I think somebody else might do a better job, then she will be palmed off to that doctor, to the experts. My job is over. I'm not an elbow expert.
Sir, what I meant, sir, you are. What I meant to say is that whatever has been done to her is such a tremendous job, I think. So to get such kind of a movement and reconstruction is very commendable.
Is increasing. She is a very hardworking. She's an artist, and this is her right hand. She's very young, so she's already back to doing most of the things, and she's very motivated patient.
Negi sir, can I have
Next case?
Yes.
Yeah.
First of all, excellent work, and as Dr. Pradeep said, it's a extensive work out there. What's the status of her lateral side? Is it unstable? Clinically, do you feel?
Clinically, she is not buckling.
She's not.
The whole worry is the point of dispute started. It was posted in some big groups. So maybe 500 people saw it. Sangeet was the first person who said, brilliant, vagera, Sangeet Gawal. Yeah. He followed me at Dr. Tanna's clinic once I left in 89. So Sangeet said, there is some shift, which I said, no, barabar hoga, bilkul, ekdam aankh se dekh ke bithaya, kaise ho sakta? But then at 6 months, I took the special x-rays and FFT also has reduced. So there is some 5 mm, 6 mm shift on the lateral side. But she's not unstable. As Dr. Christos showed, that patient was you could move it.
Yeah.
Nothing of that. And she's not on any painkiller.
But I still feel I have an opinion, because as you rightly told, we have fixed the radius and it's stable. Am I audible?
Yeah. No, you are audible.
Yes,
Yeah. I still feel, do we need to go about with the lateral reconstruction if possible? Because
that lateral side cover is not good. It's not
Yeah. I would leave it. Yeah. I wouldn't touch this thing. It was like from the beginning. It was an
Thank you.
an adventure.
That's a good.
We go to the next case.
Yes, please.
Okay, sir. We go to this one. Slideshow and from beginning. Yeah. Here is a young male, fresh fracture and no neurovascular deficit. Any opinions? What will you do and what do you think it will show? Any predictions?
Share your slides.
No,
we can't
we
see
don't-
them.
Oh, I'm sorry. I'm sorry. I'm sorry. I did not share the screen. I'm sorry. I go to Zoom and then share, and this is my, okay. We can see this case first, and then we go to that one. That was brilliant. Yeah. So slideshow from beginning. Here is a 72-year-old female. She was on BiPAP and oxygen at home for last 10 years. Pretty old, but they don't have a son. All 3 daughters are married, and the old lady and the husband, they manage all their affairs themselves. So this is how she was. And because she was on BiPAP and oxygen at home and the injury was complex, so at least 2 or 3 seniors saw her and then put her in a plaster for almost 2 months. Around 2.5 months, she was like this. almost crying because she can't do ADLs. She has to depend on somebody else for even their necessary things. What do we do? Dr. Tejas?
Yes, sir. After 2 months.
Three. This was
For 3
8
months.
weeks she came. Then I explained her the risk and the options which I have got. But then probably there were enough people to frighten her. So she took 1 month to come to a decision. Look, ye nahi chalega, boss.
I think, sir, I will gradually distract and try to reduce the elbow first, and
Okay.
openly try to do open reduction of the olecranon, as well as the remove the radial head chunk and try to reconstruct the lateral ligaments if possible.
Yes, sir. I got a CT scan done. The head radius is sitting somewhere in the soft tissues very anteriorly. You can see that there is a dent in the coronoid, but not a big fracture. So the olecranon fossa was good. These are some more images. Around 3 months down the line, she came for surgery, and all risk explained and everything under block we did it. Head radius was retrieved from the anterior soft tissues. You can see it there. It was sitting beneath the skin initially. Actually, I forgot to take the photograph at that time, so we kept it there and took it, but it was just palpable beneath the skin there. Unlike Dr. Christos, who must be having at least 64 sizes of the head radius, we get about 8 sizes. And they are not modular. They are fixed type of non-cemented hip loose metal spacers of titanium. So this was the trial head. The artery is showing the level of the trial head. It is at the level of coronoid. Sizing was correctly done, and then head radius was replaced. Then olecranon was reduced and fixed with first tension band, but it's comminuted, is pretty osteoporotic, and the fracture pattern is such that I supplemented that with a plate. So TBW with plate. This is the flexion. She is stable. Up to 20 degree of extension, she is stable. And this is almost now 1.5 years she is doing great. She is absolutely normal. Yeah.
Can I ask?
And very happy. Doing 74, she does all her household chores. Cooking and most of the routine stuff.
Yes, Christos, sir, you have a question?
Yes, sir.
What about the, have you reconstructed the ligaments on the lateral side, or you just?
I repaired whatever I could repair. I did not use a palmaris longus graft to reconstruct the LUCL.
Okay.
Yeah.
Because if it's 3 months, it's
I agree.
Nothing to repair, like from the quality of the tissue there, and
And that too at old age. So probably a palmaris longus graft would have been better.
Yeah, I use from the triceps on the back, but it's the same thing at the end of the day.
Okay. So that is your first preference graft, or if palmaris is not there, then you use a triceps strip?
No, I just use always triceps.
Okay. And how big is the strip? Length and the width?
6 to 7 centimeters the length, and has to be like half centimeter. It doesn't have to be that big. And what I do, I use mostly I use an anchor. Sometimes when I have a free button, I use a free button, supinator crest, and on the top I just dunk it with the swivel up with a knotless anchor.
Yeah.
One more question. I mean, what is the?
Yes.
Do you find it anything preferable of using tricep strip compared to the palmaris, Dr. Christos?
I think there is no difference. I think you can just extend your corporate approach, for example, and you just take it directly. Like that's the only thing about it. Otherwise, it's a preference question at the end of the day.
Thank you. Thank you so much.
One question, Dr. Christos, from Dr. Sanjay Singh, Mumbai. Is it a full thickness triceps or you take a partial thickness?
Yeah, it's mostly partial thickness. You can have a bit more. I take it partially, not the whole thing, and
Okay.
I take it mostly from the medial side because you have more tendon there. The
Okay.
tendon is thicker.
So basically, roughly the diameter would be around 5 mm basically.
Mm-hmm. And mostly, I have to say, I take 6 to 7, and I have to shorten it.
Okay.
In any case, you are using your internal brace to supplement it.
And that's a good thing about internal brace, because your reconstruction can become loose. The internal brace stiff, it stays stiff forever. It doesn't matter what you do. There's sometimes you either have to cut it because sometimes it hurts, or when you put it too stiff in there, because what I do actually, so I don't get it too short sometimes or too much tension, I put my forceps under it just to be sure that I don't tense it that much, because it's really stiff.
Yeah.
It doesn't let go.
We go to the next case.
Yes, sir.
Yes.
Yes.
Sir, one question regarding this case.
Yes, sir.
After 3 or 4 months down the line, can we just remove the radial end fragment and reconstruct or repair the lateral ligament part, and it is sufficient to not?
Sir, I did the first surgery with a DOT consent that anything can happen to her, and she said, "I'm willing for that, but I don't want to live like this."
But again, as she has excellent outcome, there's no necessity also.
She's happy. She's doing everything, whatever she wants to do. Okay. Here is a young male patient, fresh fracture. He had some other low limb fracture.
Sir, screen sharing, we are not able to.
Oh, I'm sorry. I did
No,
not share it.
Yeah.
Okay. Just a minute, sir. Zoom. एक सेकंड इसको नीचे लाओ, इसको बंद करो. I have logged out or what?
No, you're online, sir.
Online, okay. Just a minute. ये रहा, एक second. I share the screen.
Yeah, please, sir.
So here is the screen. Is it seen now?
Yes,
Yeah,
yes,
make it.
yes.
Okay. Yeah, now it's full screen. So now, can you see it?
Yes, sir.
Yes.
Yes.
Yes, sir. Here is a young patient, fresh fracture. He had some other injury in the lower limb also, but that's not relevant, except that it did not allow him to start walking next day. No neurovascular deficit. So what will you like to do, and what do you expect to see on the CT scan after seeing this X-ray? Any predictions? It looks pretty innocent. It doesn't look that damaging, as we will see.
Yes. Pratik, sir. Dr. Pratik.
Okay. Same. I can see this olecranon fracture, which is communicated, as well as there is a part of the
Radius.
trochlea.
Yes.
Sorry, radius. Yes.
Yeah, that's very important, this side.
Yeah. So this is the part I can see, and there is
Here also
part
something
of
is seen. Something is
yes,
seen.
yes,
Radial.
definitely, sir, definitely, sir. Some indentation or fracture along the head.
Some fracture is there.
Fracture is there.
This
Yes.
is how is the CT scan.
Capitulum. That's
One
it.
piece is there, one is there.
Yes, 2, 3 pieces, and combination, sir. Combination. It looks like some impaction also.
Yeah. Real bad injury.
Bad injury, sir.
Yeah. Here are the axials. Actually, I should have put them first. This is the thing. This gives the severity of the injury. This is trochlea, only this part is intact. This one is damaged. 1, 2, a lot of damage.
Correct.
So we chose to operate obviously with a posterior olecranon osteotomy approach. Many of these shear fractures I do with the lateral approach in the supine position if it's a pure shear and the posterior column is intact. But here there was a natural olecranon osteotomy done by the injury. So that part was settled, issue was settled. And ulna was contused, but it was in continuity, it was seen. I don't like to put a sling around it. It was left in its bed after it has been seen throughout the course. This is medial side, this is the shoulder end, this is the wrist and the elbow distal end. Again, the medial side. Here are the loose pieces. Medial column is intact. That's my only saving grace. And these are two big pieces of the trochlea which are free. So they were kept on the table. There were more pieces to come. 1, 2, 3. So 5 people were there to solve the jigsaw puzzle. Each one opined, isko aisa nahi, aisa lagao, aisa fit hoega, aisa hoega. And finally we found out the correct lie of those pieces, and this is how we could reconstruct it on the table. And 1.5 mm K wires, this was reconstructed up to here. Then we took a Verbrugge, which was holding the metaphyseal humeral part, and we rotated almost 90 degrees. So now has gone here, medial part is here, and now we can see the trochlea 360 degree almost. Yeah, here. The medial soft tissue is intact. We did not disturb it. The part which was reconstituted here has been put back in its place, and the wires, K wires have been passed. And there are new 3 or 4 K wires which are attaching this fractured trochlear part to the metaphysis. Here comes the X-ray. So these are 1 and 2 first K wires which go into the medial column. Wire number 3 and 4, they go into this metaphysis and fix the fractured part of the trochlea to humeral metaphysis. And you are seeing one buried K wire here, 1.2 or 1 mm K wire. So trochlea, this whole trochlea is now hollow. This much of the graft could be packed inside this trochlea is unbelievable. This all cancellous graft, so much of graft we could push into this hollow trochlea to reconstruct it. Otherwise, there was a fear that this may just collapse later on. So plenty of graft packed here, and you can see a void in this area. So that was another free piece of the trochlea which we had kept on the trolley. So this was here, and here is that buried K wires. So this wire has been, this piece has been punched here with a fine spine punch. And this is the K wire, which you can see here, 1 mm K wire, which goes and stays there. Because I was worried that it may migrate in the joint, so I took out the tip here and bent it so that if it won't migrate and if it's hurting, then I can take it out from here. So then we saw the depressed head radius. Annular ligament, you can see we did not cut the annular ligament. We just lifted it with a fine periosteum, lifted it and fixed it with 2 headless compression screw on 1 K wire. And then we got a lateral column, intra-articular lateral column plate. That's an Indian plate, I think titanium one. This LCP was initially held with K wires, and its height was adjusted, and I like to pass the distal most screw first so that I know that I can't go any more lower down than that. And there was a 1 thick K wire, this one. This thick K wire. So this was replaced with a 3 mm headless compression screw to leg the bigger chunk of the trochlea with the medial shaft. And these are some more pictures. The joint is congruous, and the tension band again for the olecranon. And these are the various views. No screw is longer, nothing is going in the joint. Other than one, here I use 1 K wire and 1 screw for the tension band, and then the plate. These are some more images. And we started mobilizing next day. You can see the amount of soft tissue damage he has got. This is the range on second day. And 4 months down the line, and I think it's now almost 9 months. This is 4 months. He had a fairly satisfactory range, and this is now 1.5 years. Actually, he sent me a WhatsApp video today, but I couldn't insert it. That's how he is.
No need of a video, sir. Pictures are saying all the story. He must be very satisfied.
Yeah, he's happy. So,
We never know. There is no established technique for this. It's our sense of reconstruction, our expertise, and our on-table sense that how we go ahead. So many pieces we accumulated together and perfectly in an anatomical fashion, and the reconstruct with the small K-wires and screw, whatever you think on table, whatever our conscious allows, and then final the result matters. So I think great job done, sir, and we
yes.
for us learn a lot.
I want to say one thing. It requires a lot of patience. And I see my friends operating with an OT boy and other thing. It's a team effort. You require people who understand orthopedics, and you must call your friend, whomsoever you are comfortable with. Because
personally,
That's right.
what I say, because whenever we have such a case, I'm not a very marathon surgeon, but you know, when I get such cases, on a single day, I keep one case only.
Yeah,
I don't want to do any case
absolutely
after
right.
that.
Yeah, absolutely. This is 4.5 hour job. And you are mentally tired at the end of the surgery. You don't.
Yeah,
It's very, very exhausting. Plus, if you've got hands who really can help you, orthopedic surgeons trying to help you, because you can't take care of everything.
Definitely, sir.
Yeah, it's absolutely teamwork.
To summarize the inventory you ordered, so what are the inventories you ordered in this
Unlimited. Unlimited. Look, I will tell you, I worked with Dr. Tanna for 10 years. So he's so meticulous in planning the surgery. This surgery will be planned for almost 2 days in his head. Or if you are chit-chatting or chana murmura shamko evening tea pe kha raha hai. So things will be discussed, may require this, you keep this. And the whole is like Sancheti Hospital keeps a stock of plenty of implants, always strive. So we keep huge inventory, which is always available. Even if we have ordered that guy and if he has not kept it, something from our museum we will be able to use. We keep plenty of implants, always, they are personal, basically they have been bought. You like something, you just buy it and keep it. It may be used once in 2 years, but it can bail you out.
It always helps whenever we are in dire need.
Yeah. So beside whatever has been ordered, there are lots of things which are accessible, always pre-strike. So we are never in a soup. This is not there, or that fellow has not kept it. That situation never arises. Even lots of distal tibias, I use a philos. Medial femoral condyle, I use a philos. So all those things are surgeries for the medial femoral condyle HOFA, but if you want a philos, it will be there.
If there is no olecranon fracture and only this type of comminuted capitulum, then what will be your approach to reach the bone? It's
my preferred approach, if there is no posterior column involvement significant, if it's a small undisplaced, I don't bother. Still, I'll go supine position, tourniquet, and anterior approach. Actually, I have got a series of cases, shear fractures. There was a webinar which was done by Dr. Chandak. Randy Bindra was there. He talked about distal radius, and I talked about shear fractures. So there is a series of cases, almost 5, 6. Sometimes we can go through them. They are all done by this lateral incision.
Yes.
There is basically there are 2 plates. One plate is this lateral column plate, which with a flange which covers the posterior aspect and the lateral, and there is a small radial styloid plate, which I twist 90 degree and use that as an anti-glide plate over the capitulum here, so that that anti-glide plate, I twist 90 degrees. So my distal screws are going in and pushing the capitular part, and the proximal part, they go front to back. And in the capitular part, they go at an angle. So there are two plates. One radial styloid plate, which is placed on the anterior surface as an anti-glide plate. And there is a lateral column plate with flange. So posterior, lateral, and the anterior, all three areas are covered with the screws, and the mobilization starts on almost second day, even in a 70-year-old. They do well. I keep them in slab for 3 weeks if they are really bad, but they are actively doing it, putting the slab again and removing it themselves, and they get a very good range at 6 weeks.
Dr. Tir has some question. Yes, you can ask
Yes, sir.
directly.
Yes, sir.
Yeah. Good evening, sir.
Excellently
managed
Thank you, sir.
these complex cases. Sir, I have a question for second and third case. How are these patients doing in a coronal plane stability wise? Why I am asking this question is like I want to know. So in acute scenario, we are not addressing, the ligament, the structure. That is what we want to send out.
Look, every elbow dislocation without a fracture has significant ligamentous injury. Okay? All of us reduce that elbow, and hardly anybody without a bony injury goes for a ligamentous reconstruction, and yet we know that almost 95% do not develop any chronic instability. Everything heals up with mobilization, and we don't keep them in plaster now for more than 5 or 6 days or 10 days maximum till the soft tissue swelling settles. Plain dislocation elbow reduced without any fracture is mobilized from first week onwards, maybe second week onwards, and they all get full range. Almost none develops chronic instability. So the same thing happens here. If you put back the bone in perfect position and achieve a normal anatomical contours, healing, and yet you are confident enough to mobilize it, he gets moved. It becomes like a non-complicated dislocation for him. Even those bad shear fractures of the trochlea and olecranon, they are all mobilized from day one. The fixation is strong enough to survive 3 months. By that time, bone has healed. And upper limb, if he develops a small arthritis at 4 years, they are not bothered. He has got a full range. His bone architecture is near normal, and he has got a good function. Both these old lady and the young guy, he drives. He is an agriculturalist, so he does all his hard work. He can drive a motorcycle, and that old lady, her needs are less. I agree. Probably, if she had been a very heavy manual worker, she might have some lateral instability. But all that she wanted to was cook, do household chores, take care of herself, choti, bath, and all those. She can do all that. She's so gaga. In the young guy, I agree. Probably that lady would have required a LUCL reconstruction.
Yeah. Thank you, sir.
Thanks, Negi sir, for the wonderful and illustrious cases. I have certain questions for Dr. Christos. Am I audible?
Yeah, of course.
My question number one what is your cutoff limit when you choose between your repair and augmented internal brace and you shift toward a reconstruction? So that's my first question on that.
As I said, if I decide for just internal brace and repair, is in this gray zone. Of course, I'm more aggressive now, and lateral I do always internal brace. But in this window, I will always use repair and internal brace. And all the time, I never had any problems. So I didn't have to do a reconstruction on top of it or afterwards. And there is another paper from April, KSSTA, from Ziebenlist from Munich. It was a cadaver though paper, and he just used he actually compared reconstruction, LUCL reconstruction, and internal brace, and it was exactly the same results. He got the same results. So maybe in the future, I haven't done it. Maybe in the future we can use both or just internal brace at the end of the day, because anyway, it's stiffer and it stays for longer. We have to see. I don't know yet, but it was a paper on, it was on cadaver though. So I have to see what it's going to be next.
Oh, do I take the point that you go ahead with repair and internal brace even after 3 months? Maybe in a gap of...
No. After 6 weeks for me is a reconstruction. It's reconstruction.
And when you're going with a reconstruction, do you always add on with an internal bracing?
Yes. Yes.
Always.
He's proposing actually he might do only internal bracing, not the graft. He's proposing.
That's a good point.
I don't know. I said in the future, maybe that's the future. But even when I do my reconstruction, I do my internal brace. I didn't do that before. Now, after I saw this paper, I always do internal brace.
I think it's a valid point because I have some cases where I have do the reconstruction. I think the most important point, as told by Dr. Christos, is the stretching of the tendons, because it gets stretched and we do have a little bit of grade 1 or sometimes grade 2 laxity. I think adding on, as I recently shifted, or maybe last 1 year, when we do internal bracing along with the reconstruction, we really do not get those kind of complications. Yeah, I think there's a point. What's your take on that, Nagi-sir?
If I'm doing it at 6 weeks, I will do the bracing also because it costs nothing. You are already there.
Exactly.
Dr. Christos,
yes.
You finish off. I'll ask my questions after that.
Okay. I just wanted to say, I've seen grafts that failed. I haven't seen internal brace that has failed.
Yes.
Your voice was breaking, but what I could gather was that your threshold for repairing the medial side is very low. So you always repair the medial side, because the conventional wisdom was that you do the lateral repair and other things and then check if it's stable up to 30 degrees, you may not have to do anything on the medial side.
Almost. Actually, I do a repair on the medial side most of the time. But because it takes just a small incision anyway, just put an anchor and I do a repair. I do an internal brace though, if I have, for example, in that case with an old lady, a flexor rupture, then I'm gonna go ahead and do an internal brace because it's more than that, what I have. Otherwise, the repair, there are some studies from Van Riet, and they showed actually that you still get some medial laxity if you leave it like this, even though that Roger Van Riet leaves it like this. He leaves the medial side, even though his papers say otherwise. And so I just do just a small incision, put my anchor in there, I repair it, and end of story. It's, yeah, I do it most of the time. I just do a repair though, most of the time.
What do you use for internal bracing?
Fiber tape.
Size of the anchor and the material.
Fiber tape.
It's fiber tape. That's how it's called.
Okay.
Yeah, Arthrex.
Arthrex fiber tape.
That's from Arthrex. If you want, you can take some tapes. If there is from My, take some Perma tape. There's different companies.
Every company is.
The only thing I have to stress here is you don't get 3.5 knotless anchors from all the companies. That's the only company that has 3.5 anchors. Then, because I've seen, so I looked for some other anchors generally in the market, but that's the only company that has 3.5. And on top of that, they are maybe the strongest, because I've tried many anchors and they broke, especially in the supinator crest. That bone is so strong, it's so hard, you get everything broken.
You apply a metal anchor.
No,
metallic anchor.
no. That's PEEK.
Thank you, Dr. Christos. I have part 2 of my question for the audience, take a little gone to the technical aspect. So whenever you're doing your reconstruction, how do you look upon or how do you decide your isometric point is my first question. And second question, when you are deciding on a combined reconstruction with an internal bracing system, what is your preferred technique of reconstruction? Do you use double tunnels on the converging double tunnels on the distal humerus and single tunnel on the and two tunnels on the ulnar side, or what's your preferred technique? And third question, when you have combining both reconstruction with an internal brace system, I always find there's the deciding the points for the internal brace anchors is a question of doubt, because you have two tunnels there and you need to put the anchor also over to that. So how do you choose the point of fixation for the internal brace anchors when you have a concomitant reconstruction tunnels there?
So what I do is I use sometimes take a K wire, just put in there, and I see where the isometric point is by having the in pronation anyway, the arm, and I see that in 60 degrees. Anyway, I fix it in 60 degrees of flexion. And what's really important for me is that in extension, doesn't matter if I have a bit of laxity. I need it to be tensed when it comes to into flexion. Yeah, and sometimes I use a K wire, I have to say, when I do the reconstruction. Otherwise, this clamp, as you saw it. And when I do my reconstruction, I do exactly in the isometric point one tunnel that goes actually proximally and posteriorly, and then I do it one more tunnel on this side, so
Y, you get a Y.
I can pull afterwards, exactly, and then my swivel lock or my anchor, I put it in there free, without having something on it, just free. You can put it, of course, you can leave your fiber tape, but for your graft, you just put it in there, you dunk it in there. So
you put your swivel lock on the Y tunnel, the central tunnel of the converging one, is it?
Exactly.
Okay. So that balances the isometric point of both. So you do not take a separate tunnel for your anchor for internal bracing.
No. I always do a single tunnel on the lateral side. On the medial side, I do a double bundle.
And how about on the ulna?
What did you say? Sorry.
I'm sorry. How about on the ulnar tunnels?
I just, as you saw, exactly in the internal bracing. That's how I do it. I just don't go straight to it, because you don't have enough length there, and you need at least this 3.5 is like 15 millimeters. So that's why I just go in this way, like, not directly vertically. So I have some. It's exactly the same as I showed it with internal brace.
Internal, but when you're trying to do a reconstruction, how do you place your tunnels?
Exactly the same.
Same. Perfect.
And it's exactly the same.
Thank you for the wonderful.
Thank you, sir. You have a case to discuss.
Hello. Hello.
Negi sir, have you any case remaining to discuss?
आपने बोला नहीं था, नहीं तो मैं तो और डाल देता. Actually, it was very interesting. Not operated, but not operating also is sometimes a very, very difficult choice. It was a plain elbow dislocation in a young person, dominant hand. The person who reduced it, he felt that it's grossly unstable. And I know him, he's a competent guy. So then he was seen by X, Y, and Z, and everybody wanted to operate on him. And he came to me, I got an MRI done, combi scan done, and we conserved it. And there is a nice, good, almost now 9 months follow-up. He's back to normal without surgery. So it's a difficult call. Sometimes not operating also is very, very great. Patients are very grateful.
Sir, what happens, what I want to say, such fractures, usually such people or such patients keep on going and wants to consult many surgeons. And when they understand the gravity of the problem, they try to correlate or contact with biggest of the names. And sometimes I have seen such people going for arthroplasty. Very common, I have few cases which they were advised arthroplasty and we reconstructed rather. me and Dr. Tejas were there in our institute, we have reconstructed such patients, and always after reconstruction, this feeling is very gratifying, sir, because we are saving and we are reconstructing, saving the anatomy
That's
and
great.
preserving the joint. That is the best thing, sir.
Yeah,
So
in person,
that
nothing
is
but can.
fantastic.
Actually, this net thing has made the life very easy.
Bilkul.
You don't have to decide there and there. The whole thing within 2 or 3 days goes to Dr. Tanna, somebody like Randy Bindra, or whomsoever you want.
Correct, sir. Correct.
Lots of people. It's a tumor case. It goes to 5 onco specialists, ortho specialists,
You
and
are
you
absolutely
can
right.
tell him, "Okay, boss, come next week." You will have
Yes.
a variety of opinion, and then we'll discuss what is best for you. So
Correct,
all
sir.
those guys, they help you.
Definitely, sir.
Who have got immense experience with it.
Definitely.
So it's around 1.5 hours. Any questions?
Yeah.
Remaining?
Can I have some last couple of questions for Dr. Christos?
Yes, sir.
Do we have time? Yeah, I'm sorry.
Yes, sir.
Yes.
Dr. Christos, my question is on your arthroscopic point of view. Do you always start your case with an arthroscopy in all cases, or?
Not in all cases. Not in all cases.
No, I mean in cases of where you're having instability, PLRI.
No, that's what I mean. Like if it's a chronic case, yes, I'm going to start with arthroscopy first. If it's not a chronic case, it's an acute case, maybe only if I'm not that sure. If it's like these 7-10 days, I can get an MRI. I think that it's unstable, the elbow. There I'm going to do elbow arthroscopy first, diagnostically, and then I'm going to go on and I'm going to repair or do internal brace. As you saw in this young lady there.
And cases of coronoid fixation with arthroscopy, what is your cutoff limit? What is your technique of preference, especially with arthroscopic assisted fixation?
The screws actually that you use there, you can do it arthroscopically, and of course, you can bring your pull-out sutures as well, either or you can do it on top of that. But the key there is that you're not allowed to put your screws too deep in the joint. Otherwise, they're going to cut your fiber wire or your suture.
Do you like using your ACL aimer devices for that, especially when you're doing a pull-out?
Yes, for sure. I don't want to do it freehand.
Yeah, sometimes I think I used to use the ACL aiming devices, but now I am more comfortable with using the meniscal root repair aimers that is more smaller, and I think it's easier to do that.
That's a good idea. Thank you.
Thank you so much. Thank you so much.
Thank you, sir. What is your preference technique for coronoid fixation?
If head radius is fractured, the life is very easy. You keep the head radius on the table, and then you can see them, take the sutures and pull through. For me, cost is a huge constraint. So anchor and all those things is a very, very important aspect. So it's so far more cheaper to, if head radius is fractured, then there is ample space. You can take the sutures and make tunnel in the ulna and then tie the knot here at the end of the surgery. Finish off your other work. If it's a big chunk, sometimes I have put a plate, but then that's a split FCU approach. If there is a medial facet fracture, bigger one, then I tend to use, we don't have those special imported plates which books go on showing. I use plates for the head radius and the neck radius. Some of that will fit, or lower end radius, fragment specific smaller plates. They are Indian copies available, so you can use something like that there, 2.4.
Thank you, sir. Can I have a last? Yeah, I'm sorry.
Was it for coronoid fractures you use the palmar plates?
Yes. Palmar plates or the head radius plates, because the plates which are available to you are simply not available, or they are too expensive if they are available.
Thank you, sir. Can I have a last and final question for you?
Yes.
For me.
Rather than a question, it would be a personal doubt just for assessment. So this was, I do not have the detail to share you on screen now. He was actually a 55, 57 years guy. As we know, the Indian scenario, he was an unreduced elbow dislocation for more than 3 years, if I'm not right. It was totally unreduced for more than 3 years, complete restriction of movements, no activity. On examination, he was unstable. X-ray and wise, there were actually, technically speaking, there was no fractures except for a small avulsion from the coronoid. The MR, both the side ligaments are gone completely. The medial and lateral gone for a toss, totally unstable elbow. And if you look at, weirdly look at the articular cartilage changes, there were grade 3 osteoarthritis OA changes, grade 3 OA changes, but he was just 55, grade 3 OA changes. So I was left to a toss. What could be the plan of action, this thing, sir? What would be your suggestion to do in this case? I'm
Dominant
sorry,
hand, non-dominant hand.
it is a non-dominant hand, left side, sir.
He wants something to be done.
Yes, he wanted something to do, and the main thing he wanted was the movement. I am sorry, I'm not able to share anything. I was not prepared
some
for that.
sort of distraction device to stretch the soft tissues and get some semblance of length and then probably.
What about doing arthrolysis, reduce it, and then in second stage?
No, but he already had grade. Yeah,
he says that grade 3 changes, so
yeah,
probably it's heading towards a replacement.
Actually, that's what I did. Actually, I was very spurious of doing it.
But you did it one go. You could do it.
I did it one go, sir.
So soft tissues were not a problem.
Soft tissues, yeah.
Years is it?
Yeah, that was the point that we really kept on mind. But as you rightly told, cost issue, and he wanted something to be done. We did have a lot of clearance in Trop, and we went ahead with doing Conrad Murray system. Yeah, I mean, he's now, I think it's 2 years follow-up right now. He's okay. He's fine as of now. I'm not sure if it's the right choice of modality.
Because of his age.
Yes, because of his age, sir. And we all know that elbow system is not, I don't know. And we had explained about the option of arthrodesis either, which he was not keen on. I'm sorry, I'm not able to share any pictures because I was not really prepared. I just wanted to ask you a question just as an expert opinion.
The first thing you wanted was movement.
Yes.
Sanjay sir, you have a question to ask?
One question, sir, to both Sir Dr. Christos sir and Dr. Negi sir. So young male, 25 years, like I saw one patient just before the lockdown, a terrible triad, coronoid gone, MCL gone, and radial head gone. So the line of treatment, young patients like radial head shattered. So either replacement or leave it alone. So like you do repair the MCL also along with the coronoid, or many people leave it alone after the radial head. So opinion on both of you. And what to do with the radial head? Should we replace in young patient, like mainly like there are studies that longer follow-ups are not that good because they tend to over pressurize the lateral side of the joint. So opinion. Yes, sir.
Should I start?
Yeah, sir.
Yes, sir. Please. Yes, sir. We are waiting to listen to you.
So exactly. So with the radial head, okay, maybe 25. If I can repair it, if I can reconstruct it, of course I'm going to go for a plate. Otherwise, I wouldn't go for a resection, just for a resection. I would put there as a prosthesis.
Okay.
Otherwise, in the coronoid fracture was an anterior medial. I have to address that as well. I would go and address that as well. From the medial side, I use a Hotchkiss approach, not the FCU split.
Okay. So you have the coronoid and MCL in the both sitting, like from the same approach. So Hotchkiss is a better for the coronoid fragment and.
Exactly.
Okay.
So I have both of them on that side. Yeah.
Sir, Negi sir.
The way you are describing that the head is shattered, probably it will have to be replaced.
Yeah.
And now even Indian copies are available. So they are not that expensive. So the choice of the modularity is not there, and the choice of the size is limited vis-a-vis neck length and the size of the head.
Yeah.
So what we do is that we order it from 2 or 3 different companies, and each one has got, so there is more variation available in the neck and the stem length and other things. So there is little more comfort. So whatever fits best. Coronoid, if it's a piece which I can bite with the screws, something like what he said, that ACL jig or some device, so you can leg it. If it's a bigger piece, if it's a smaller piece, then once the head is out, you can take the Ithlobond or whatever suture fiber wire you want to take, and then make a tunnel in the ulna and tie it. So it goes like this. But I won't hesitate to replace the head radius. There is no way you can leave the head radius unreplaced. Unlike what professor said, I'm not very keen to open the medial side unless I'm forced to. So if it's stable, say up to 30 degrees, something like 30 to 100 degrees is stable, I won't open the medial side, I'll conserve it. So maybe post-operatively I'll keep in a history.
You'll take care of the coronoid through the radial head itself, no, and do not go on the medial side.
सब दिखता है वहाँ पे, यदि बड़ा पीस है तो दिखता है ना उसमें वो. Actually, most of the times, having taken the incision, you don't have to dissect anything. You have to just keep away from the posterior introitus and all vital structures. The trauma itself is so much that it has dissected all the things there. So the you have to do very little dissection in first week. It's all done there. And medial side also, when we open, sometimes I wonder, we say that I will take a Hodgkin's or a FCO split. But the moment you take the incision, the trauma itself has made the planes. So you just follow the planes and don't damage anything.
By the time MCL is gone, many times we have a tear of the medial structure also. Everything is, the muscles are
Actually, I will like to share one practical Indian experience from a very respected and experienced side. Dr. Tanna has got a talk and a series of cases. Indian copies of the head radius replacement are available only last few years. So when they were not available and he was in a soup that, okay, you need head radius replacement, but it's not there on the table and it's not there, going to be available in a day or so also. So just open the medial side and do a nice, good reefed up repair of the MCL and start his mobilization in a hinge fixator, and all those 6, 7, 8 patients he has got a collection. They did fairly well. When head radius was required to be replaced and wasn't available and was not done, the medial repair salvaged the elbow from getting subluxed. And he shows 2 years follow. So if you are really not having it or don't intend to replace the head radius because of one or other reason, you should open up the medial side and do a nice good MCL repair and the flexor tendon repair on that side.
Can I ask you something? Can I
yes,
ask
sir.
something?
Yes, sir.
The coronoid fracture, you actually address it from the lateral side, or if you open it up from the medial side, you do it from there?
I start from the lateral side. Okay. If head radius is in 2 or 3 pieces go on the table, then there is probably ample space to see. If it's a big piece of coronoid, through the same window I'll open it, then probably I'll finish my lateral side repair and all those things, head radius replacement, other thing, and then I will check it. If it is stable up to 30 degrees, I may not even open the medial side. If it is not stable, then there is no choice. I will have to repair the medial side. And those anteromedial facet, there is no choice. You can't do it from the lateral side. You will have to go medially. So they are done with a medial incision.
Then,
through the medial incision.
Can
but if it's a fracture which can be legged with a screw, then through the same window you can do it.
Can I have one question to Negi sir and Dr. Christos? Yeah. We all know that when we are going for the radial head prosthesis, the dreaded complication or the fear we have is overstuffing the joint. For the sake of audience and for everyone, what are the tips and tricks intraoperatively that you can use to avoid that, sir?
Answer?
Please, anyone, sir.
Yeah. One is about the height. Yes. In the lateral view, as in one of my patients, I showed that the trial is a plastic one. So you can keep a metal marker at the top of that and you match it with the coronoid. It should be 1 millimeter below that. Then, if in doubt, because we are really strained for the choices. And these people probably have got 64 sizes
That's
available.
what-
We have got only 8.
But that's
So,
the point I wanted to ask you.
out of the 2, choose the smaller one, not the bigger one.
Yes.
Then perfect AP of the elbow like this, you will get only on the table, never probably after that, post-operatively.
Exactly.
So in that AP, you take it and see that the shadow of the joint line which olecranon forms, that lazy S type of curve, this is smooth. Head radius and all that is smooth. It's not overflowing outside the, so it's not broadened, that ulnar side is not broadened. So are on the slightly smaller side. In the head radius, if you can reconstruct the head, it's not exactly a circular thing. One diameter is few millimeter longer and another one is at slightly shorter. So most of the time, the shorter diameter is the correct size.
Right. I think that's a valid
As I
point.
said that, ask it from 3 different companies. So something will fit it. Don't be biased, I want to use this only. But they are all different. 3 companies make their own versions.
Now, as rightly pointed out by Negi sir, it's a point with Indian copies, as he told, because we have a lot of constraints when you're using the size. Do we have any points from Dr. Christos?
Yes.
No, I totally agree. I see the lesser sigmoid notch, and that's how I do it. At the end of the day, it's exactly what you said, actually.
Thank you so much.
Even take a point here.
Can I ask you, Professor, one thing? Do you ever have to take out the head radius because of one reason or other? Have you taken it out at some point of time? Radial head prosthesis. I think he can't listen. Professor Christos? No, I think he can't listen. Anyone has an experience he had to take it out?
Yes, sir, I have.
Can I make a point here?
Yes, very much. Welcome.
Yeah. So EP view of elbow on the of the contralateral side, as well as the wrist AP view should be taken pre-operatively and compare after trial reduction. That will help.
I think most valuable point is the smaller size, because what I do, I measure the reconstructed head and I just take one size smaller, because I also answer one question of Negi sir. I removed one head done elsewhere. It was so painful and tight that I had to no option. I had to remove it and change it, because it was the same problem. It was oversized and it was stuffing the whole elbow. His movements were very much compromised and it was tight. So painful. So I always opt for a smaller size. You also gave same tip, sir, and very valuable tip. We should always opt for the smaller size.
For saying something.
Yes, Sanjay sir.
Yeah, sir. What I saw practically was during my fellowship, my bosses used to follow the inner ring of the radial head and used to choose that size, not the outer ring. So if you reconstruct the radial head, you see the dome falling down. So that rim, they used to take it as a size and I used to finalize that. So they used to err slightly on the smaller side and used to decide that we have to match this ring, not the outer ring.
Currently, it comes one size smaller.
Yeah, deliberately undersize it.
Correct.
I have a question. In case of overstuffing and you have stiffness as well and stuff, what do you do after that when you're going to remove it? Are you going to remove and do an arthrolysis and then do put a new one in there, or you're going to do all of it in one shot?
I did it on a single shot because it was just few days after the surgery. No need to get the arthrolysis done. It was few days only. I think.
Yeah. I mean, 2-3 years after that.
Yeah. Because in compromised movement,
take it out. May not replace it after 3 years.
Definitely.
Yeah. The patient is, let's say, 25.
Just take it out. Don't replace it.
Don't replace it, even in this age.
Probably they will do well. The Indian experience about head radius excision in isolated injury is great.
Okay.
When there is no
Doctor,
other soft tissue component, so at 3 years we presume that everything else has healed.
Well, we would like to listen Dr. Christos' version. What you suggest, sir?
They will replace it.
I would replace it, but not in one
Two
stage.
stage.
That's
Two
two
stage.
stage again. I'm really like a fan of two stages, because first I want to give some emotion there, and then in the second stage I put the prosthesis in there.
Dr.
Great.
Christos, a point to add.
May I add something here? In India, 90% of the patients, even if he has agreed on day one for first stage surgery removal, he will not turn up for the second stage.
Point well made.
He won't come.
Dr. Christos,
Even if you get a written agreement, he won't come.
Dr. Christos, I have one point to rather question. Like 25, young guy with a radial head prosthesis at the end of 2 to 3 years, I think the most common problem in a well-done case will be a synovitis. Is it what you're trying to say or something? Or you have a loose prosthesis?
No, my problem is not it's the synovitis and the stiffness. That's why I want to give some motion first.
And then, do you personally feel going ahead with an arthroscopy to do synovectomy and did a little bit of arthrolysis would help, or to push on some more years with the same prosthesis? Because I had one case of that.
No, I wouldn't do that, because at the end of the day, the problem is being caused by this prosthesis. So you haven't won anything. And it's maybe the only case where I would do the arthrolysis open. Otherwise, I do it always arthroscopically, because I'm going to open up anyway. So,
second. So you don't feel that you can push on some time with this thing? Thank you. Thank you.
So I think
ours and their system is different. Their insurance is paying, and
that's right. That's right.
System is different.
Exactly, sir.
So I think if there is no question, Negi sir can conclude the session. It's around 2 hours.
Brilliant, sir. You are doing a great service to Indian orthopedics, as I am always saying.
Thank you.
Herculean effort. In 1 year, in all the conferences, hardly 5,000 people must be sitting in the hall. When stars are on the dais, top guys, there are 50 people, hardly 50 people sitting. The rest are all on the stars or shop, sightseeing and other things. And here 10,000, 12,000, 15,000 people watch your channel every day is unbelievable.
It's all, sir, Dr. Ashok Shyam's effort and his team, sir.
Yes, unbelievably great effort. He's a genius. He has done a Herculean job.
He used technique and this technology very well, sir, in our field of orthopedics.
And I believe the way conferences were being done, they will never be the same again.
Exactly.
Because guys like you and me, who used to sit in the hall, they won't like to take the trouble of going to attend that conference. And those sightseers, they will go, but they don't sit in the hall. So slowly it will die out, I think.
I think
this
Corona
will become the norm in 5 years.
Corona has changed our entire life pattern. So
that's right.
It's the new normal.
Yes, sir.
New normal. But certain things will change forever.
Yes. Thank you, Nagisa and Dr. Christos, for the wonderful and illustrious structure. It was really useful.
Thank you, Professor.
Thank you.
Namaskar.
Thank you all.
Thanks.
Dr. Ashok Shyam is not there, sir.
But convey my heartfelt things. Huh?
Yes.
I really feel very strongly what he has done for us.
Thank you, sir.
Thank you
Great
very
efforts.
much. Thank
Salute you.
I think Dr.